without further ado, let's go ahead and get started. So thanks for joining us, everybody. We are here to talk about the legislative scorecard for 2022. If you all might remember, we did one for 2021, so we are back for a second round. So let's talk just for a few minutes about what a scorecard is and kind of who we are. So we're the Arizona Oral Health Coalition. We are a dedicated cadre of oral health advocates that exist to address oral health disparities in Arizona. So as the AZOHC continues to advocate for better access to oral health care for all Arizonans, it's important to understand how our elected lawmakers vote, who sponsors progressive oral health policies, and who tends to stand in the way of that progress. So this scorecard really informs lawmakers that Arizonans care about oral health issues and that we take notice when lawmakers care too. So that's really why we do the scorecard. We started doing them last year. We're going to hopefully continue to do them every year. Again, it just really lets the oral health community know that, you know, we are paying attention to bills that have to do with oral health and public health at large. And hopefully we'll get to the point where we're very influential and lawmakers will also take note that we're taking note of the way that they vote. All right, so before we go into it a little bit more, we're just going to talk about kind of understanding the scorecard. So I did put those links in the chat. If you see, the first one is a fact sheet that's really just going to kind of give a very broad overview of how lawmakers voted. But if you click into the second link, you're going to get into Bill Track 50, and that has kind of a little bit more of a complicated way that it's set up. But you can see the scores in different ways, and we'll go through that when we kind of get to that point. But overall, we awarded points. 3 points for floor votes. So if a bill was on the floor, everybody should have had the opportunity to vote on that bill. If they voted the way that we wanted, they received 3 points for that vote. If they voted in committee, so not every lawmaker had the opportunity to vote in committee, but if they did, were in the committee that heard a certain bill, they were given 2 points for their vote in committee if they voted the way that we wanted them to, depending on our position on the bill. They received 1 point for sponsorship. So this also includes co-sponsorship. You'll see on the fact sheet, it's denoted by stars, I believe, on the fact sheet. And so one of the stars is primary sponsor, and then I think it's either a smaller star or a silver star is going to be co-sponsor. So on Bill Track software, they can't really denote between primary or co-sponsorship. So when you look at the actual Bill Track 50, that second link, if you click into it, you'll be able to see there's a little asterisk, that's primary sponsor, and then all of the co-sponsors. As far as points were awarded, if you co-sponsored a bill, you also received the 1 extra kind of point there. And also absentee votes did not count against the score. So if you weren't there for the hearing for whatever reason, it just would show up as a 0 on Bill Track 50. So it wouldn't be a negative or a positive point. So if, for example, if someone voted the way that we didn't want them to vote on a bill, they would receive a -1 or a -2 or a -3, depending on if it was a floor vote or a committee vote. If they were absent, it'll just show up as a 0. So we do want to just call out that Senator Mendez and Representative Salmon were both out on parental leave for a majority of this session. And so they're not featured on our fact sheet just because they have like 0s, and we didn't want that, you know, to be conflated with other folks who have 0s because they actually voted the way we did not want them to vote. So they're absent from the fact sheet. If you go into the actual Bill Track 50 program, you'll see that they have, you know, quite low scores, but that is just because they were out on parental leave, which is something that both CAA and the Arizona Oral Health Coalition support, you know, parents being able to do that. So just wanted to call that out. All right, and so one other thing to note on understanding the scorecard is the lawmakers vote index or percentage score. So you're going to see their raw points based on those floor or committee votes when you click into the program. But on our fact sheet, you're only going to see the vote index or their percentage score. This is a lot easier to digest because it's very much like, you know, what you would see on a report card in school. If you got a 90%, that's, you know, pretty good. That's an A. If you got a 79, that's a high C. So it kind of correlates that way. The way the vote index is calculated is by dividing their total points earned. So that's the number of votes a legislator casts the correct way by the total points possible. So the number of opportunities that lawmaker had to vote. And so that's then applied to the vote index, which is on a 0 to 100 scale. So again, you can kind of think of that as more of like a letter grade. So on the fact sheet, you'll just see the vote index, much easier to understand than the points. When you go into the bill track program, you'll see both of them laid out. But the vote index is really what will give you the best kind of overall idea of, did this lawmaker support our priorities or not? All right, so a word of caution. We always like to put this before we delve into the scorecard. The legislative process is a lot more nuanced than our simple scoring methodology can ever explain. There are many factors to consider. There are bills that never made it to committee. There are bills that maybe passed but didn't make it into the budget. And there are other just complex circumstances. Party politics is messy. There's no foolproof way to ascribe weight to a policymaker's intentions, whether they truly acted in favor of oral health equity or not. So one of the examples I kind of like to give here is chairs of committees. So chairs have a lot of power in assigning bills. So for example, Joanne Osborne, chair of the Health and Human Services Committee, decided not to assign, for example, the dental hygienist scope of practice bill, which Deb is going to talk about here in a little bit, for a committee hearing. And that was due to a lot of political reasons, which I'm sure Deb will touch into. But that effectively killed that bill, even though you'll see that Joanne Osborne has sponsored another one of our priority bills, which is great, and has 100%. She voted the way that we wanted her to on all of those bills. But again, the perspective, she also did keep another bill from going forward that we wanted. So just some things to kind of keep in mind when you're looking at this. It paints part of the picture, but there's no way that we can paint the entire picture just using algorithms and software and methodologies. And again, oral health, like this session, like last session, and like many sessions before, was not and has not been prioritized at the state legislature, despite our consistent efforts. So we're hoping to keep pushing forward. All right. So now we're going to talk about a little bit about the priority legislation that we have on our scorecard. So these are bills that were on Arizona Oral Health Coalition's priority bill sheet. And we had a few more, but these were the ones I really picked out to score lawmakers on because they either most closely were related to oral health and oral health equity issues, or kind of public health and public health equity issues that have an alignment with oral health in some way. And you'll see what I mean when we get to that. So the first one was SB 1112, dental hygienist scope of practice. And I'll let Deb kind of explain about this bill for you all and why we had it on our bill list.
Okay, thanks, Brianna. I want to jump in and make a correction on the slide. It died in the House, not the Senate.
Sorry about that. You're right. The Senate did vote for it. Yeah. My bad.
Yeah. No problem. And as the slide says, SB 1112 was sponsored by Senator Bartow, and she's been a pretty good oral health champion in many areas, even though we don't always agree with her in other areas. It's one of those things. But she did this at the request of the Arizona Dental Hygienists Association, and it basically sought to make what we considered to be rather modest changes to the scope of practice for dental hygienists. And we wanted it would authorize dental hygienists to establish a dental hygiene diagnosis, a dental hygiene treatment plan, as well as some limited prescribing.
Okay.
We're getting some feedback. Yeah, thank you.
You're good, Deb.
Anyway, some limited prescribing authority in terms of topically applied agents that are preventive or therapeutic in dentistry, like fluorides, like prescription strength fluorides, whether they be rinses or toothpaste. That might be the most familiar type of product or type of agent that might be prescribed. So both the dental hygiene diagnosis and dental hygiene treatment plan were defined very clearly in the law as well. And it was meant that those definitions clearly laid out that they were not dental diagnosis. They were really limited to what the dental hygienist can treat or address in preventive or other ways of addressing those problems. So it's much akin to a nursing diagnosis. Nurses don't do medical diagnoses, but they do nursing diagnoses. What can a nurse do to help this patient? So basically, that's what we're looking at here. What problem do I see the patient has that I, as a dental hygienist, could address in my scope of practice? So in the simplest terms, we saw this bill as really simply aligning the legal scope as defined in law to align with what dental hygienists are taught in their CODA accredited schools, programs. But more specifically, if you want to go into the benefits of it, we felt like it would improve communication for patients, as well as across providers, because you could be more specific. It would streamline patient care and would improve access to oral health care, eliminate some of the red tape that might inhibit the way a practice can run efficiently. And, again, to put more simply, all licensed practitioners should be able to provide the services that they're educationally qualified to provide. And so the bill did move through the Senate rather easily, probably due to the sponsor being Nancy Bartow. So but that went pretty smoothly, but it did get held up in the House. Chairwoman Joanne Osborne of the House Health and Human Services Committee is rather hesitant to ever hear a bill that is not a consensus bill when it comes to scope of practice type issues. So she wanted there to be some consensus or some sort of effort between the two groups because the Dental Association was adamantly opposed to this bill. And so she wanted our two groups to come together. We had attempted that well before we even got to the legislature, I might add, but we're really almost stonewalled, just got a no, and that was pretty much it. Now, at the behest of Joanne Osborne and the bill sponsor, the two groups did come together, met. We didn't come to any agreements during the meeting, but after the meeting, there was some compromises offered by the Dental Association, but they were found to be not acceptable to the leadership of the Dental Hygienists Association. So that's basically what happened. And going forward, we do believe that we will try this again. The position that they took was so interesting because, and I have this in writing actually from them, because basically their opposition was rooted in, they simply just didn't see a compelling reason to make these changes, especially when it comes to performing a diagnosis or prescribing. And additionally, they indicated that the entire coding and billing infrastructure described in our coding manuals puts the responsibility for diagnosis and treatment planning in the hands of the dentist, which we acknowledge, saying that this doesn't replace a dental diagnosis. Dental hygiene treatment planning and dental hygiene diagnosis are not billable procedures. We had acknowledged all of that ahead of time. And acknowledging that it's not a replacement for a comprehensive dental exam or a comprehensive dental treatment plan. And we feel like it too often, these kinds of questions are framed that way, like there's not a compelling reason to do this. And yet when you look at that question is really meaning that any restrictions on practice are the default and have to be somehow overturned, when really we think it should be the other way around. Why shouldn't a practitioner, a licensed practitioner, be allowed to do anything and everything that they are educationally qualified to do? Why should there be restrictions when there's no compelling reason for the restriction? So our position is that there's no compelling reason to keep restricting this, because dental hygienists are very well qualified to do this and have been for many, many, many years. So like I said, we will try this again. One of the tactics that we will try is to identify as many dentists as we can who would support this position. And we know they're out there because, quite frankly, this is already an industry standard. In other words, dental hygienists are already doing this in practice. So, there you go. We just want to codify that and make it legal. That's it, unless you have any questions.
Wonderful. Thank you, Deb. So this, again, was a bill that we supported and unfortunately did not make it through, died in the House, not the Senate. Does anybody have any questions specifically on this bill at this point? Otherwise, we'll keep going. Feel free to unmute and ask them if you do. All righty. So next up, we have some great news. I'll have Zeta Diedoff, the Director of Health Policy at Children's Action Alliance, talk a little bit about SB 1272, which is Access Postpartum Care, and HB 2551, the Children's Health Insurance Program redetermination, sponsored by the first one, Tyler Pace, and then Regina Cobb. So the governor signed these bills and they were funded. Yay. All right, Zeta, take it over.
Hi. So we'll start by talking a little bit about Senate Bill 1272, sponsored by Tyler Pace. This bill extends postpartum Medicaid coverage to a full 12 months. For many people right now who fall into kind of a limited eligibility category, coverage ends at 60 days. And so we recognize that a lot of postpartum deaths, a lot of postpartum morbidities are really occurring after that mark, and that it's really difficult to keep people connected to services for things like substance use disorders. Say they start getting treatment during their pregnancy and are expected to just have figured it all out at day 60 postpartum. The same goes with postpartum depression and many other kind of physical health ailments as well that require more than 60 days of treatment. These postpartum and pregnancy mortality and morbidity disproportionately impact communities of color in Arizona, in particular Indigenous communities here. And so this is going to be a really helpful source of coverage, not just for individuals, but to help support rural hospitals so that they can ideally help keep those services open to more people for longer and more sustainably. We had to get a little creative with this. So just so as a little bit of background, one of the COVID relief bills made it easier for states to adopt this option, this extension to 12 months. And it's locked in by Congress for 5 years. So we can be guaranteed that we'll have this ability for people who are qualified for 5 years. In order to keep the costs down, the sponsor and our Medicaid agency worked to craft some language and discuss with CMS the kind of implications of it that will help the state move people into other coverage categories at day 60, which often come with a juicier federal match associated with them. So the state will be assuming less of the cost. It got the cost of this bill down to about 2.7 million state dollars. I think especially right now, especially in this post-Roe world that we're living in, this source of care is going to be especially critical, and that it's going to help ideally save some lives. So really excited about that.
Yeah. I have a question. First of all, I mean, this is a great victory for us, and I'm happy to see the postpartum care coverage extended an additional 10 months. But what does the data show in terms of, you mentioned that our moms need coverage beyond the 60 days, but what does the data show in terms of, in an ideal world, how long would we have this actually right? Is it past 12 months? What does the data tell us?
I think ideally everyone would have health coverage at all points in time.
Right.
They'd have health coverage pre-conception. And then, we know that there's an association between children's coverage and parental coverage status as well. I think that what this bill is immediately trying to address is the kind of correlations between prenatal care which we know is impacting infant health outcomes, and you know, in the heartless, like, economic side of me, also impacting overall costs to our healthcare system. But it's also meaning that, you know, babies are born severely premature when their parents aren't able to get the care that they need during pregnancy. I'll have to look back to the maternal mortality review data, but I want to say that 2/3, don't quote me on that, 2/3 of deaths were occurring after 6 weeks postpartum. And so, you know, it gets a little like wonky and, I don't know, complicated when we start talking about like pregnancy related versus pregnancy associated deaths, and severe morbidities. But the groups that were at highest risk of postpartum mortality were the groups that had lost their health coverage, had lost the connection to that healthcare, who in Arizona in particular are more likely to be American Indian, Alaska Native, and Latino individuals are much less likely to be covered during and after pregnancy. So,
And I don't know if there's, you know, so I'm gonna also make an assumption that now that mom is covered, those additional months, that the likelihood of her children going in for their visits increases, right? If parents have healthcare coverage, then there's more likelihood that then the children have it as well, and that they do get their required visits. Is there any way of tracking that? Is there any way of, and I don't know, I'm just curious if that's what comes out of this. Does that make sense?
yeah, I think that's a really good point. And one of the things that gosh, I cannot remember who it was at this point, but somebody recently brought up that this isn't just about, like, you know, mom getting in for a 6-week checkup, or, you know, the parent getting in for postpartum depression treatment. It's also about, it's about the ability to form a healthy bond, and it's about the ability to integrate services in new ways. So one of the things that, you know, we talk a lot about is if we can do that postpartum depression screening at the child's 3-month visit, as opposed to before they turn six weeks or something like that. I'm thinking back to like my own kids, visits, and I feel like we were there like every 2 days for something, for some visit or another, some shot. But if you can continue integrating those screenings for things like postpartum depression and like parental morbidity factors at the well child visits, then you can help actually direct the parent into the care that they might need as well. So I know ACOG's been looking into that, and AAP have been talking a lot about that, like how to maximize the dyad, I guess, is like, I feel like they kept calling it the mother child dyad after I had my kid. But right now it's really limited when, once that kid turns 6 weeks, like that parent might not have coverage anymore. And then I think too, just, when we look at like Medicaid as a whole, Kim, and I know you know this, but I'm just going to say it like for the sake of everybody, like the improvements that have been made to hospitals and health systems as a result of Medicaid coverage to begin with have had a tremendous impact already on things like infection control in hospitals. Like just having that ability to get people in, to have their services be covered, to add a payer to the mix, in particular in the case of ITUs, like is super duper critical to reducing infant mortality or to reducing maternal mortality and morbidity. And then, the whole system benefits from that source, if that is helpful. And there's also some evidence that's, I'm sorry, Brianna, I didn't mean to cut you off.
Oh, I was just going to say, if you could also, when you're down to 1272, I didn't mean to cut you off there on your thought, but give us, a little bit of an overview of 2551, and then maybe just for maybe some folks who might not, this is the first time they're kind of hearing about these bills, how these are kind of related to oral health as well. And
sure.
I apologize that I misspelled Tyler Pace's name on here. This is why I should not put together presentations when I'm at a conference. So I'll
like Tyler Pace
before they go out. Yeah.
Yeah. So sorry, just one more note on the postpartum. I think that there's also been some really amazing data that's come out about the relationship between Medicaid expansion and maternal mortality and morbidity. And states that have expanded Medicaid have had this tremendous reduction that has not been seen in the states that are non-expanders, as we say. So I think that there's really, correlations across the board that like healthcare works. So, which is good to know. And then as far as it relates to oral health, we know that pregnancy and the postpartum period are times of great shifts in a person's body, that, all kinds of wacky changes happen. And that right now we do only have an emergency limited dental benefit in the state capped at $1,000 for adults. However, this will ensure that people who are falling into a slightly higher income bracket can actually access that emergency dental benefit for the full year after their pregnancy ends. So say they do, have a major tooth infection, need to have a tooth pulled, they would be able to access that care that previously they would have lost at day 60. And then one of the big things that's, I think, really important about this opportunity at the federal level is that any covered service that's eligible for Medicaid reimbursement in the state must be covered during this postpartum care. So you can't offer a limited array of benefits. That was a question that came up a lot with lawmakers, like during the course of this stakeholder sessions was, well, can't we just limit it to like OBGYN care? You can't. And that's great, because that means that when we do get an adult dental benefit in our Medicaid program, that will also extend to all adult populations, regardless of, whether they're pregnant or postpartum. And for this particular group, it's a slightly higher income bracket. So that's nice. As far as House Bill 2551, this bill is a little bit complicated to explain on its face, right? So if a child qualifies, if their household income qualifies for Medicaid or CHIP at any point in the year, in theory, they are eligible for coverage for a full year. But we know that what really happens is that all kinds of different things ping in the Medicaid system that say this kid's income has gone up. It could be something as simple as, a parent picks up a couple of extra hours at work and gets some overtime pay that would throw them over the income threshold. There are some checks and balances that are in place for that, but we know that especially right now, as places are short-staffed, as wages are going up, it can be really helpful for parents to have that like ramp off, right? So we don't want them to just hit this cliff where your income is now at 207% of the federal poverty level. Your rent has gone up 25%, but your kid's also going to lose their health insurance coverage. So figure it out. So what we're hoping to do with this bill, and why I think it's especially critical right now, is because for the past year, kids have been insulated from coverage loss, right? Or since the beginning of the pandemic, I should say. It's been more than a year, which is kind of sad to say. Kids have been insulated. They've been able to stay on health coverage, even if their parents can't make their CHIP premiums that month. Usually that's like $10 to $75, $75 per family. So it's, pretty low monthly payment that the parent has to make under normal circumstances. Right now, they can't be booted if parents can't make that payment, or if their caregiver can't make that payment. If income goes up slightly, they can't be booted. And that's been really tremendous. We've seen so much less churn in terms of health insurance enrollment. And one of the things that I think is really critical to point out about that is that churn often isn't a real reflection of like a change in the family's household income, right? It's a temporary fluctuation, or it's a one-time bump in terms of what they've gotten. And what it means is that parents, have to complete this paperwork. If their child is found ineligible, they lose their health coverage. A couple months later, they might be back in the same financial situation they were in before, and they have to go through the full process of reapplying. Right now, we're at limited capacity for eligibility. We've seen some PES offices close or relocate. People don't know where they are. People are being encouraged to call in by phone. They may or may not have folks on the line who can speak somebody's preferred language, or their most comfortable language that they speak. There's a word for that I'm completely spacing on, so I apologize. And they're also being directed to the website. And we know a lot of people, don't have internet access, don't have a computer in the home. don't have the skills to use that website or don't know the intricacies of their applications. So Kim, just because I know you're on the line, I know like for tribal members, this is especially tricky because there are certain types of tribal income that don't count for purposes of access enrollment or kids care enrollment. And knowing those ins and outs can be really tricky. So, you know, families are just kind of constantly in this cycle of like getting kicked off, having to re-enroll, getting kicked off, having to re-enroll. What this bill will do is, at least for those kids who are enrolled in our children's health insurance program, Kids Care, they'll be able to stay enrolled year round, even if their family income changes. This bill, really importantly, did not encompass our Medicaid population yet. We will be back next year asking for that, and we're also hoping that the federal government will take upon itself you know, continuous coverage fix. But from what I'm hearing right now, that's not going to happen in this round of budget reconciliation. There might be another kind of family health omnibus bill that might come down in the future, but not yet. So this is a good thing for Arizona kids for now.
Thank you, Zeta. That was wonderful. And again, children on CHIP can access oral health services. So that's kind of the tie there.
Thank you.
All right.
Sorry, that was like the whole point. Thanks, Brianna.
No, you got it. So we'll go kind of quickly through the last ones. We don't have a whole ton to say on them. We had 2 policy experts on the call with us for the previous bills. But another one that we had on our scorecard was HB 2083. This was diabetes management, which was sponsored by Joanne Osborne. This one did get signed and funded. And this just essentially expands access so that patients will be able to receive self-management training services. So basically diabetes medication management as prescribed by their primary care practitioner under specified circumstances. So this is, I think, paving the way. Again, I think expanding Medicaid to cover any service is to increase, you know, access to healthcare is a step in the right direction. And we know the correlation between diabetes, of course, and oral health. So just wanted to call that one out. That was a good win for us there. And then we have tobacco. We could probably go on and on and on about. I know we've talked about this in many calls, but I'll just give kind of a brief overview here for you, because I know we also want to get into kind of digging around in the scorecard. So we had 3 tobacco bills that we ended up scoring lawmakers on. HB 2125 was the good tobacco bill. That's basically just what we were calling it. That was sponsored by Representative Udall. This bill was good because it included a retail tobacco license, which was housed at the state health department, not at the Department of Liquor, which is where they're wanting it. Let's say the tobacco industry wants it to be housed at the Department of Liquor because they're kind of oversight and the wheels turn really slowly. And so it's not as good. So this bill would have put it in the health department. No preemption. So for those of you kind of new to the term, basically without preemption, this would allow cities and towns to regulate tobacco policies such as marketing and the location of retail shops, you know, how far they can be from schools and places where children gather, things like that. So it would give cities and towns that power. What preemption does is sets a standard in the state law and kind of ties cities and towns' hands to be able to do anything above and beyond what the state law suggests. And so the tobacco industry and all of their bills, they're kind of one of their main goals is to get preemption in there so that when a state law is passed, they can, you know, hopefully be kind of in control of that language, then cities and towns won't be able to do anything about it. They'll be able to market, you know, however they want according to the broader scope, closer to schools and children and things like that. So preemption is generally very bad for cities and towns when it comes to public health. So this bill would have prevented that. It would have raised the sale age from 18 to 21 to come in line with the federal statute, and had, you know, pretty progressively punitive measures for retail shops. Severe penalties, including license revocation, you know, after a time, but also did not include any criminal penalties for youth. So we don't want to see the youth who are being targeted and marketed to then turn around and be criminalized for the possession of these products. It's, you know, on the retail shops would bear the brunt of those penalties. This also had good definitions of tobacco that prevent the tobacco industry from using loopholes to kind of exempt vaping and other synthetic tobacco products. So this bill did not get it didn't pass. So all of these bills, I'll just go ahead and say none of them made it through. So that's good and also bad because the tobacco bill would have moved us forward, but we did stop some of the bad bills. So that brings me to the next bill, HB 2505. Basically, this bill was known as the Wolf in Sheep's Clothing Bill. This was Toma's bill, was essentially remaking the bad tobacco bill, SB 1245, which Leach sponsored. They tried to kind of put this through at the 11th hour. It didn't have preemption in it to begin with. That was kind of how they wanted to cook those votes, but they planned on having a study committee that would have then added in preemption, and that was the kind of whole political strategy behind that. It was, again, very complicated. And as we mentioned at the beginning, there's so much that goes into this. So it's hard to just kind of give a score, but this was a bill that we were opposed to because of that aspect, particularly the preemption. And then the bad tobacco bill obviously had preemption, housed at the Department of Liquor, would have raised the age to 21, but had questionable definitions of tobacco, basically an industry bill. And we all know what the industry's end goal is. So those were the tobacco bills. We played good defense, so none passed. All right, and then some honorable mentions here. These bills we included.
Brianna, I have a question.
Sure.
Do you know if the tribes weighed in on any of those tobacco bills? I'm not an expert in this area. I know tobacco is, kind of separate. We do some tribes do have tobacco shops. I'm just curious, did they weigh in? Was there anything of significance to share with any tribal testimony or anything like that?
Yeah, no, unfortunately not any testimony or anything like that. I know, what was it? I know that last year, the tribes had kind of taken, it was either like kind of like a neutral stance on it. I know there was a lot of, I think they had said that the regulations wouldn't necessarily impact the sale of tobacco on tribal lands. Again, I'm definitely not an expert in that, but I think that the tribes have somewhat kind of stayed out of the tobacco.
Got it. Okay. I kind of suspected that, but wasn't sure. If anything comes up in the future, let me know. But I think we can think, I think they're pretty neutral. Okay, thanks.
Yes, that's my understanding as well. But I think that continuing to have that tribal engagement is something that I know the tobacco partners are really hoping to do. So thank you for that, Kim. And then again, I get some honorable mentions. We added these in here because we wanted to award the sponsors for these bills for putting forth the valiant effort every year to introduce some of these, important oral health bills. So they received, the sponsors and co-sponsors received an extra point. All of these bills never got assigned, never got a hearing. They were all Democratic sponsors. And so that's likely why they never got a hearing. You really need to have a Republican sponsor and a Republican majority legislature to get a bill in front of a committee and be heard. But there was HB 2704, which was Access as Preventative Dental Care. And that was sponsored by Representative Shaw. And this would have just provided expanded access to provide preventative care for folks. So right now there's the $1,000 emergency benefit, which you can only use pretty much if you have dental trauma, your tooth gets knocked out, something like that. But this would have provided that preventative care, which is a step in the right direction, but would not have been comprehensive or restorative in nature. But again, a step in the right direction, didn't get a hearing. And then the two pregnant dental care bills, which would have expanded access to allow pregnant people to receive preventative and comprehensive dental care. So that's 2206 and 2306. Jennifer Germain and Kelly Butler sponsored those, and they put forth a bill, I think, almost every year for the past, I don't even know how many years. And so we want to applaud them for, continuing to make that effort. All right. So now I think we'll kind of just go ahead. I'll pull up the Bill Track 50 template. We can, if you have any questions, want me to look deeper into any lawmakers, we can do that. And actually, Tara, since you are on the call, maybe I'll just have you go over the scorecard as well that you made. So let me pull that up and then we'll kind of talk more about our calls to action. All right, Tara, if you wanted to maybe explain, I think you had stepped away when I tried to explain the stars and I hadn't seen it yet, so I think I did it right. But sure, I'll leave it to you to kind of talk about what you did here.
Sure. So the stars are indicating sponsors. Did you go over like the vote index and all that?
Yes,
Oh,
yes.
good. Okay, so yes, they're ordered, they're graded, and then they have stars based on if they sponsored a bill. And I just added in that the bigger stars that are yellow indicate a primary sponsor. And I realized the individual who sponsored the bad tobacco bill probably should not have gotten a gold star, so I will edit that. Again, just as we said at the beginning, please don't share this scorecard yet. It doesn't have the cover sheet, and also I gotta remove that star because I don't think you get a gold star for sponsoring the bad tobacco bill. But yes.
And as you can see, we kind of grouped these into A, B, C, and D. Again, as I explained, just a little bit easier, a more recognizable way to understand, how people did. So you can also pull this up, look at in the House, how did people do? And then in the Senate, who are our high performers? P's and C's, D's and F's. Right. So we'll also now kind of just go into the actual bill track software. And so if you all have someone you want me to look up, or we can do that too. Let me get that up. Disappeared. All right.
Can you put up pace?
Yes.
I'm sorry, it went off too fast. What was his score?
I'm bringing it up now. Yes. So Tyler Pace is an interesting one. He sponsored so many good bills. We had an oral health day at the Capitol, and he was very excited about oral health, interested in potentially sponsoring a bill this year. But unfortunately, let's see, we'll go by, I have to sort these by House and Senate. I believe he voted the wrong way on one of the tobacco bills. So I think that's why his score is a C.
There you go. Oh, yeah.
So again, when you're kind of playing around with bill track, you can come in and see. So we got a 79%. And again, that's, based on total points that they scored, based on if they voted our way, divided by their opportunities. So he was out on the diabetes management. The 0 again means that they were absent. And so then he was also absent on the dental hygiene vote. So he didn't receive he wasn't penalized for that, but didn't have the opportunity to vote on that. And then it looked like he did vote the wrong way on the wolf in sheep's clothing bill, which again, taken with a grain of salt, there was a lot of political back and forth and confusion among lawmakers with this bill because of the kind of wolf in sheep's clothing aspect. And so I think Tyler Pace is an excellent example of how the scorecard, and then he receives a sponsor rating, how the scorecard can show you a lot, but if you really don't kind of dig in or even know the politics behind things, sometimes it makes people look a little bit maybe worse than they were. So Tyler Pace is someone who I would consider, to be on our side when it comes to oral health. I think, the tobacco one was just a little tricky, but fortunately the numbers were the numbers. So let me move this so I can. So we organized it by House and Senate. You can see here their district, which again, take with a grain of salt because the districts are changing. But these are their kind of possible votes that they had based on their opportunities. Were they on the committee where the bill was heard, et cetera. And then we had the vote index. So again, that's what Tara's fact sheet really shows. So that's, really, I think that gives you the most easy to understand score and how well did they do. But yeah, if anyone has anyone else they want me to pull up, just to give an example, we'll look at some of our lower achievers. Warren Peterson. not too good on our scorecard. So vote index of 20%, score of -9. It looks like you did support dental hygienists. So thank you for that, Warren. But again, and so you'll see if it's red, that means they did not vote the way we wanted. So we wanted a no vote here, and he voted yes. That was on the wolf in sheep's clothing, tobacco, but also on postpartum, he was a no. CHIP, he was a no, and diabetes management, also a no. Anybody have anyone else they want me to pull up? You can also, of course, dive into this on your own time as well. This one is ready, just the scorecard we'll send out again with the fact sheet. And you can also click over here to sort by different, if you want to see all the top scores. I like to sort it by chamber just because that's how I kind of think about lawmakers, but you can sort them in different ways as well. Then also just to kind of go through bill track a little bit, if you want to look at the bills themselves. So again, these are all the bills that we chose to use for our scorecard. And so you can click into the individual bill and kind of see the bill text and things. If you're wanting to learn a little bit more, you can see how we rated that bill. So all of them would be either 5, which is 3 points on the floor, 2 points in committee, or -5 would be it's a bad bill, -3, -2 points. And then if there was a sponsor rating associated with that, so you can look in there. And then bill score. Again, if you want to get really wonky about it, you can go and see each lawmaker kind of laid out instead of clicking into their profile. You can see, how many points did they earn for each bill that they voted on our priority list. So that's another kind of fun thing to play around with. And this is kind of cool because it shows just kind of a visual representation across the board. Blue is for Democrat, red is Republican, how across all chambers, how did the votes kind of lay out? And if you go, you can see individual lawmakers there. And it looks like a lot of blue, but we do have some sprinklings of red, some champions there. So that's good. You can also do it by the House and see what that looks like. Or by the Senate. So some fun things. This is like a little heat map. It kind of shows by county, where support was or not. Yeah, so some fun things to play with on bill track. Okay, so if nobody has any specific lawmakers that they haven't already peeked into on their own and want to talk about, we can just kind of go back to our presentation and just kind of talk about some final next steps and some closing words here. In closing, and a call to action, we are going to be starting to really ramp up our comprehensive adult dental campaign. So there was no comprehensive adult dental benefit bill introduced this session. We had the preventative bill, which didn't get a hearing, but we're really hoping to just kind of push full steam ahead. We do have the interest from Tyler Pace. Our Capitol Day was pretty successful, and even some of those Republican lawmakers who might not have scored so high on our scorecard showed an interest when we went down and talked to them in person about the importance of oral health. We saw some love for diabetes, which we know has that connection to oral health. And we saw Medicaid expanded for postpartum care. And so we know that there is the legislature is willing to expand Medicaid for some things. So, we have to kind of take what we can from that and just push forward to try to get comprehensive benefits for adults in the next session. Right now, we are collecting stories. So if you yourself or you work with individuals who participate in Access or Medicaid and have, or you did in the past, and have a story related to accessing oral health care. Oh, Jen has a question. Pushing for chiropractic care was also successful. So I don't think we had chiropractic care on our priority list, just because I guess it's related to oral health in kind of the overall general health, but the relation was a little bit less streamlined, so we didn't have it on our priority list. But chiropractic care also did pass through, so you can go to the chiropractor if you participate in Access now and have that covered. So again, showing this kind of ability or reasoning that we see from lawmakers that they're able to expand access, which sometimes that in of itself, they don't want to expand it for anything. So we are seeing some ways forward there. So back to the story collection. If you know anyone or yourself have participated in Access and want to share your experience trying to access oral health care, we're really going to use these stories to kind of bolster this campaign. We want lawmakers to really see and understand just how not having access to oral health care impacts so many areas of your life. And so we've collected some really great stories so far. So we want to continue building that. We're going to be building out a campaign landing page, which will house these stories. And if you are interested in getting more involved with this work, you really want to just be involved in this campaign going forward, joining the advocacy committee is the best way to do that. Just send an email to azohcoalition@gmail.com. Just let me know you're interested in getting involved in the work, and I will make sure that you get plugged in.